Welcome to the third event on the 10th anniversary of the Johns Hopkins International Injury Research Unit. I'm so happy to see some of you here attending in person, and a warm welcome to all of you who are listening to this live stream. And thanks to the School of Public Health for organizing the internet live stream for us. It's always great to have colleagues who not only could not make it in person, but also who are in other countries. Particularly if you are part of the NIH Fogarty training programs, a warm welcome to all fellows and trainees listening to this live broadcast. My name is Adnan Haider. I'm a professor of global health here at the Johns Hopkins Bloomberg School of Public Health, and I direct the Johns Hopkins International Injury Research Unit. And it's my great pleasure to simply welcome you all to this seminar and introduce our moderator for today, who will then in turn lead us through this exciting event where we have three eminent speakers talking to us about trauma and really taking us from the spectrum of prevention to acute care to looking at issues of systems as well as issues around populations and individual patients. So it's going to be an exciting 75 minutes or so. We hope that you will enjoy yourselves, but in addition, importantly, learn, particularly from a global perspective, how this problem is relevant to our country, the United States, but has huge implications outside our country as well as a global public health problem. So I'm delighted that our Deputy Director of the Johns Hopkins International Injury Research Unit, Dr. Abdul Bachani, will moderate this event. He is not only our Deputy Director, but also Assistant Professor of International Health and Health Systems. His expertise is really in how do you measure disability and post-injury outcomes. He's doing extensive work. I'm sure we'll get to hear from him on other occasions, so I'll hand over to Abdul. Thank you.
Thank you, Adnan, and a warm welcome from my end as well, on my behalf, to all of you who are here in person and those of you who are online. We have an exciting session today, as Dr. Haider just pointed out. We have three speakers who've done extensive work on emergency medical systems, emergency care, and trauma care in general. And what we hope that you'll gain out of this session is that when we talk about emergency medical care and trauma care, we just don't mean ambulances. We mean that you need to focus on systems as a whole, need to use data for guiding your decisions and improving quality. And as you're listening to these lectures, to these sessions and talks, I also want to bring your attention to the special issue of the Journal Surgery that all of you hopefully received, which has a lot more papers on this topic and covers this entire spectrum of trauma care. So the way we're going to organize today's sessions is we're going to have our speakers each talk for about 20 minutes. If there's burning questions, we'll take one or two questions right at the end of each talk, but for the most part, we'll save our questions for after all our three speakers have spoken, and then have a discussion on the larger topic. So without further ado, I'd like to invite our first speaker, Professor Junaid Razak. Dr. Razak is a professor within the departments of International Health and in emergency medicine at the School of Medicine. Dr. Razak has tremendous experience in the field of emergency medical care and trauma care. He has worked for a lot of years trying to improve emergency care in Pakistan, where he also was the chair for the Department of Emergency Medicine at Aga Khan University, and then served as the CEO of Aman Foundation that runs an ambulance service in Pakistan. So, Dr. Razak, I'll hand it over to you.
Thank you, Abdul. Can you guys hear me? I guess you can. Okay. All right. Thank you. So first of all, thank you, Adnan and Abdul and Amber, for inviting me to this session. I've spoken about emergency care in Pakistan many times. And I was thinking about how do you link what I'm going to talk about to the rest of the discussions. Perhaps at the end of it, we will have a little more to add. But let me start with one very recent event. Last week, I was attending a session on trauma and emergency care at WHO. And I landed back in DC last Thursday. As I land back, I see a couple of messages on my cell phone from one of my cousins. And they wanted me to call him back. So I called him back, and they said, my dad had a road traffic accident a couple of days ago. He was riding a bicycle, was going to pick up his wife, and didn't get to the destination, so they called around. They called his cell phone, and somebody picked up the cell phone, and that's in Karachi. And they said, maybe you want to come in to this hospital because your father is here. His name was Altaf. He is an uncle to me. And the reason they were calling me at that time were that they have taken him from this hospital where he was found lying in the middle of nowhere, sort of not being taken care of. They took him to hospital number 1, and then from there to hospital number 2, a very typical story we talk about. And they were calling me because the doctors at this hospital were asking him whether to put him on the ventilator or not. So when we talk about ventilator in Pakistan, we talk about terminal event. People die when they put them on a ventilator. So I'm standing in this line at the immigration at the IAD, and they don't like you to use your phone, trying to figure out what to say. And I I really don't know what to tell you. If the doctor is saying, do this, then I guess your father should be intubated. So half an hour later, I get a message from my other uncle, and they said that he passed away. He died. So somebody I recently met, I was in Karachi, met him, and he, like many others, became a victim, very close to me, victim of road traffic injuries. And he became just a number among many numbers we get, many names and numbers we have. And the point is, this becomes very personal when you talk about a story, but this is a story of 14,000 people every day. Every day in the world, 14,000 people die of injuries. This is a huge number. And in academia, we talk about numbers. You will hear numbers, and we hear the statistics. But the reality is that these lives are quite important. Now, this gentleman, son who was 23, died last year. And that son has 2 small kids, so he was taking care of them. So the generational impact of some of these things is immense. So even the numbers and stories sometimes don't capture the pain and suffering we have because of them. Now coming to what the less personal, more academic side of things, what I want to talk about is linking Altafs and people like that in the city I grew up in, and talk about how I see emergency care. You might have heard it from me before. And then I'm going to focus on 3 things: capacity building, generating evidence of research, and system building. And I'm going to end with the last slide on what I think are the key lessons learned. So for the emergency care, we often, in the context of trauma care system, we heard that there is a need for care at the scene. We often talk about that as life-saving skills that common people have, and this is followed by giving transport, EMS, in-facility emergency care, and that goes on into the facility care, be it surgical care, interventions, radiology, blood transfusion, infection control, other things, and then finally rehab. So that's for us, for a lot of us, is trauma care system. Now the first 3 pieces of that is the bystander care, transport, EMS, and the in-facility emergency care is what I consider emergency care system. Now that emergency care system applies also to other diseases. So the impact of emergency care is beyond trauma care. So for example, acute cardiac care, very similar as would be acute stroke care today, as would be a patient with sepsis. And all of these first three components become what we call the emergency care system. Now what we need to understand is fixing one of these things do not result in improved outcome. That's the problem. We do not have a silver bullet. We don't say, well, we will fix the transport and EMS, and I spent quite a bit of time doing that, and we'll have an improved outcome. Or I'll fix my emergency department. There may be a short-term improvement outcome, but we know what will happen when the patient goes upstairs or go to more long-term care facility. So that's my understanding of emergency care, just for you know. And then also, there's confusion in the term as well. So some people define emergency care in terms of time. So we talk about golden hour of trauma care, or we talk about time is brain, or time is heart muscles. So that is a time dimension. Then you have, many people talk about emergency care for diseases like trauma care system. That's another way to look at it. Cardiac care. And then some people talk about in terms of where the location is. So emergency department. For me, emergency care is where the emergency patient is requiring emergency care. So that's the second piece. And finally, as you look at emergency care, there is an individual emergency care need, which is, as you know, injuries, trauma, heart attacks, strokes, and then public health emergencies such as wars and conflicts, disease outbreaks, etc. And as we look at the whole emergency care, some of it, even for during disaster, focuses on care of the individual. And many a times, the same system provide care for the population. So it depends what time you're looking at, what is the need of the hour. So it's a very broad approach to the whole system that you're trying to look at. So, but again, coming back to the emergency care in the context of trauma care, and I'm going to talk about our experience in Karachi. I was also talking about Pakistan. Pakistan is too big of a country for me to actually represent. Karachi itself is big enough. Depending upon what numbers you look at, the population is between 21 and 24 million, one of the largest cities in the world. Just to give you a context, the population of Karachi is more than population of Maryland, plus Delaware, plus Pennsylvania, plus DC, and half of New York State. So this is a very large population, all of them living in about half the size city of that state of Delaware. So a lot of people living together in a very complex, congested, urban environment. And this is where most of us, myself, Amber, Dr. Huba, who's visiting from Karachi, we as team worked on a number of these things that I will share with you. So these pictures, they're older, but some of them actually still relevant. There's a big disparity between the availability of services. So you can have some pretty decent facilities and some which need a lot of work. And that disparity is primarily determined by whether you can pay or not, but also more and more by the capacity of the system. So even today, if you're willing to pay and are able to pay, you may not be able to get high quality of services. You might be waiting for some critical life-saving facilities. So coming to the specific activities in Karachi, specifically in Pakistan generally, I'm going to talk about capacity building. That I think is it's less of a money issue, I think, It's more of people issue in most of these settings, so capacity building is key. We'll talk about, again, evidence and research, and finally system building and the experience with that. So this is the list of, a sort of boring list of where you need to, how many people are involved, or what kind of focus you need to have in capacity building. For us, we start with the easy undergraduate training. For us, this is the physicians and nurses who are going through the basic training, focusing on them as their emergency medicine training. But a couple of things which are very important to me, and I think that hopefully will have a huge long-term impact. It is training residents, people who are going to be specialists in this area. People are going to be not only practicing this day to day, but become leader who will bring in change. The change is driven by leaders, people who believe in it, and that requires a lot of training. So, we started with first formal training program where we used to work, and then moved on now to a national program. Currently, there are 6 programs, emergency medicine. Research training, Adnan, Dr. McKenzie, myself, many others have been involved in the Fogarty training program, and we'll talk about that a little bit. We also worked on pre-hospital training. When I was there, we had an urban health institute that trained 400, actually took nurses and trained them over 6 to 8 months to advance EMTs and paramedics. While we were doing all this, we realized that our cardiac arrest outcomes were bad. We got some funding to train about 20,000 people in CPR, and most of them were your policemen, your teachers, students, college students. And then actually, very importantly, most importantly for me was faculty training. And many of the faculty members who came to US through the Fogarty training program, but some actually went to Canada, for example, Dr. Huba. Most people had not attended an international meeting in emergency medicine who were faculty. So getting that exposure, just that there's a big world out there. Most people did not have any publication when they started as faculty. So getting them to think about research and teaching and all that. So a lot of that happened in terms of capacity building. Now, specifically, I think for the research piece, I'd like to talk about the long-term training through the Fogarty training program with Hopkins and AKU. 24 people trained at master's level. We had 3 Fulbright fellows. One who was not part of the Fogarty training program went to be CDC EIS fellow, and one person went to Harvard for a master's program. Several others, almost all of them actually stayed back. We currently have 1 PhD student, 2 master's students, and we expanded the impact from Pakistan to Afghanistan. Several thousand short-term training and several publications, more than 100 peer-reviewed publications. And this is ongoing. I left Pakistan 3 years ago, and the number of publications, other things have actually stayed up. So that's a really great feeling for me, because things have not died down as many people were thinking. For generating evidence, for us, the question was, or for me, the most important part was data systems. So we have this huge population that are using emergency care system. How do we capture that? How do we develop a system data collection? Some of that, actually, our publications were around that. Then we focused on emergency care diseases, a burden through that, and then finally, availability of system, access and quality. And I'll share with you a couple of things that, this was last year, BMC emergency medicine, just like you have for surgery, number of papers came out. Now, just to give you a sense of what is coming through the emergency departments in Pakistan. So it's 7 emergency rooms, and these are chief complaints. And as you can see, it's very interesting, first, second, and third, fever, injuries, and chest pain. So if you talk about dual burden of disease or triple burden of disease, you have infections coming through either first or second throughout, and then you have, of course, injuries. And in this table, what we did was we actually excluded from injuries head injuries. Because if we actually include head injuries to injuries, then injuries become actually number one, except for one age group, as a reason for visit to the emergency room. But fever, chest pain, abdominal pain. So you have, global surgery, people talking about the burden of disease. A lot of abdominal pain probably requires surgical evaluation, if not surgery. Infectious diseases, your cardiovascular diseases and injuries as most common reasons for visiting to the emergency department. Actually, for me, what was most interesting when I started working, trained in the US, started working in Pakistan, was fever. So every other patient with fever is, what is this fever from? For us, fever is sepsis and we sort of focus on it, but here, you try and look for cause and you can't find often the reason because you have, typhoid, malaria, dengue, and a lot of times they can't be diagnosed early on. So that's one set of slides. The other I wanted to show you was a couple of very interesting findings, factors associated with ambulance use. We found out again, people with injuries are 3 times more likely to use ambulances than those without. So primarily for us, when we were talking about EMS, we were talking about injuries and trauma. Within the same thing, at that time when we were looking at Karachi, Karachi had the highest utilization of ambulances, primarily because we had a lot of trauma, we had a lot of violence, but also we have more availability. And there are other places in Pakistan where the availability was limited. So for us, maybe it was a positive sign that people are using it more and more. I don't have the numbers. We also looked at the short-term outcomes, and people who are coming by some ambulances had better outcome than others, and we can talk about it in the discussion session if there are more questions on that. Also, we also looked at the quality of care, right? Patients who come in, who are being brought in, they're pulseless. How many of them actually had CPR done? So if you look at about 1,500 patients who came in pulseless, about 50 out of 1,500 had a CPR attempted in the emergency room. And that is, 4 or 5 years old data, I granted. But then you talk about, well, patient is dead, why should we even attempt? Why should we even try? And so you get a huge issue with the quality of care. And distribution-wise, male, female, we have pretty similar numbers. You have maybe a little better CPR rate in the private sector than public sector hospitals. And then finally, coming to a somewhat different topic of chest pain, and we were looking at the quality of care provided to chest pain patients. If you look at, one of the things we do here is cardiac enzymes. It's a chemical test that looks at the cardiac injury, and overall, if you see 7% in males and 3% in females actually had a test. These are adult patients with chest pain who had a test that is highly predictive of the eventual outcome. So we identified a number of issues in terms of quality of care, CPR, trauma care, and otherwise. So the third piece I want to talk about is a very interesting experience that very few academics get, is to build a system from scratch in a private sector. And we were given a mandate to build emergency care system, but also a primary care system, a health information network, and capacity of the people. And I just wanted to focus on, within the Aman healthcare, we were able to work on ambulance service, the paramedic training program, and the CPR. And the reason I'm showing this slide is, we can talk about it for hours on various things. But the question we were grappling with, the EMS system can work only if there's a system existent. And if you're looking at population health, engaging communities, engaging ambulances, and then providing telehealth services to people who actually can't access care a lot of times, we thought that would be useful along with multiple other capacity building. So, and again, some of the activities with care, I'm just going to, the plan was that we will have community health providers providing services to the community, and when they get sick, they can call EMS. We had systems so we could categorize hospitals into which hospital would be better suited for that kind of patient. It didn't always work out very well. The patient were taken there, and then when there was no emergency, but people were not sure, they could call telehealth and get information on how do we take care of these patients at home. So that brings me to my last slide. So a lot of this, talked about capacity building, some basic glimpse of research and a system development. But what I learned really is that there is a huge unmet need. And what was most interesting was that actually there's a huge space for innovation. And those of you who are interested in doing things differently, and what we do here in the US often is not, as we know, applicable or useful in those settings. But innovation, there's a huge space for innovation. And with innovation, you can actually have a rapid success. The second point I wanted to make was human resources is the biggest challenge. It remains a challenge in LMICs. People go there, they leave. People like us who are from there, who spend some time back in the US. Of course, followed by institutional capacity for innovation. Thirdly, as I mentioned, quality is a significant challenge. But at the same time, sustaining the change is a bigger challenge. And then finally, how do we finance some of these things where there is a private sector providing some of these services? And how does the government engage with private sector? And there's actually a pretty interesting trend these days, especially in parts of Karachi where I'm from in Pakistan, where there's a government engagement as a funding agency instead of running the services. And that, I think, has a huge scope and huge potential for improvement. I'll stop here and take a couple of burning questions that Abdul said.
Thank you, Junaid, for that excellent overview of emergency care systems and the need to look at systems as a whole. Does anyone have any one or two burning questions? One question there.
Thank you. Very, very informative. I think Sir William Osler said what the mind does not know, the eye cannot see. So in one of the things which you mentioned, that is health education, do you think forceful legislation where it comes into the textbooks and as well as on television would actually bring it to the mind space of people? Because in India it's the largest cause of death, road traffic accidents, and if you see, it's very slow, the traffic is very slow moving and very congested. So do you think forceful legislation which brings it into textbooks of students and a fixed amount of time for television ads being delivered for social messages like this would make a difference?
I think they alone will not make that big of a difference. They have to be. So I think that when you start talking about road traffic injuries and make people realize that it is an important issue, it helps the enforcement piece. So people, at least from a Pakistan perspective, will be more serious about wearing helmets. They will not fight with the policemen. They will not, because they have been primed. But just having education does not solve the problem. Just like we know that we educate physicians about smoking, but the smoking rates are similar in physicians and non-physicians, nurses versus non-nurses. So if education was the answer, we would do that. But I think if you link it and combine it with other things, then it's useful.
Thank you.
Thank you,
Thank you so much.
Junaid, for that. One of the main things that came out of this talk, for me at least, was to be able to improve systems, we need to understand what's happening, what the needs are. And that's one of the things that our next speaker, Dr. Amber Mahmood, is going to focus on how do we use data to understand what our needs are for trauma care, and how do we use that data to improve services at the facility level or out in the field. But I believe our discussion is going to focus at the facility level. Just by way of introduction, Dr. Mahmood is an assistant scientist within the Department of International Health. And she also serves as Associate Director for the Johns Hopkins International Injury Research Unit. She's a trained surgeon. She received a training in Karachi, Pakistan at Al Khan University. And where she practiced for 7 years and then finally saw the light and joined public health full time. So Dr. Mahmood, over to you. Thank you.
Thank you, Abdul, for this very kind introduction. Dr. Junaid is always a tough act to follow, but I'll try. And as Abdul said, that I will focus mostly on the facility level trauma care and use our work in Uganda as an example of how systematic data collection could actually help in capturing some of the burden and care-related issue, even in low-income settings where most of the focus actually goes into resource and capacity development. So let's start there. This is the outline of my talk. A few initial moments will be spent on injuries and trauma care in low-income settings. And later on, I will introduce you to our project in Uganda, which focused on traumatic brain injuries across the lifespan. And the third part is actually an analysis of the traumatic brain injury TBI registry that we implemented in one of the largest tertiary care hospitals in Uganda. Injuries are, we have just heard about how big a burden injuries are, but it is also important to understand that the differences, there are differences in the burden and the outcomes of injuries when you look at low income versus high income and middle income countries. And in this slide, which is not very clear here, you can sort of see that in low socio-demographic situations or countries, the burden still is largely dominated by communicable diseases and maternal child health issues. But injuries, when all forms of injuries, including violence, wars, and interpersonal conflicts are taken into account, then injuries actually become the largest burden after, and this is also true in middle-income countries where the epidemiological shift has occurred slowly over time, and although the dominant part is taken over by non-communicable diseases, mental health and injuries are still in top most causes of burden of diseases. In low and middle income countries, the issue of hospital-based trauma care was actually brought into light by the virtue of increasing incidents of road traffic crashes and resultant injuries, as well as interpersonal violence, which is kind of very common. And now the conflict situation has risen to a level that both in the acute setting and in long-term rehabilitation, injuries and violence become a major burden of hospital-based and facility-based care. While in many settings, and when we focus into low-income and resource-poor settings, a sheer lack of resources, both in infrastructure as well as in human resources, combined with a lot of operational effectiveness is actually striking. And although this part has sort of brought a lot of attention of the funding agencies and also international organizations, it is also important to note that lack of supportive functions to assure quality of trauma care, like trauma registries, quality improvement initiatives, in-house training for providers, also plays an important role and has been identified as a major barrier in low-income trauma care settings. So now I will try to focus on our work in Uganda, and I said earlier that we will use the case study of traumatic brain injuries across lifespan in Uganda. So a little bit of background, TBIs are actually dubbed as the silent epidemic globally. And according to WHO estimates, approximately over 10 million people in the world suffer from traumatic brain injury each year. And compared to the global levels, the incidence in sub-Saharan Africa is actually a lot higher. And even within sub-Saharan Africa, countries like Uganda, Kenya, and Zambia have a humongous burden of not only TBI injuries, but also resultant short-term and long-term disabilities that occur due to TBIs. And this is despite the fact that injuries and deaths are underreported due to not only poor surveillance, but also difficulty to access care in a large majority of these countries. So a little, we can talk about numbers all the time, but to give you a sense of injury burden in Uganda alone. So a recent study from Kampala estimated an annual incidence of 116 injuries per 1,000 population, which is a very high number. And the injury mortality is also at comparative to other countries is very high, and it is estimated to be 220 per 100,000 population. Now, if you focus on TBIs amongst injury burden, the estimated cumulative incidence of TBI hospital admissions is 89 per 100,000 population. So admissions is okay, but if you look at the mortality, in different studies, it has been reported from 45% to 75%, depending upon which hospital and which level of care you are talking about. So this is not only a huge burden, but also a huge mortality that results from TBI alone. So our project in Uganda was a tripartite a collaborative effort between Makerere University, Johns Hopkins International Injury Research Unit, and the Mulago National Hospital. And we focused on improving the TBI care within Mulago Hospital, but the goal was to define the health and economic burden of traumatic brain injuries across the lifespan in Uganda. And we used this tripartite collaboration to achieve a number of different activities, including engagement with stakeholders, capacity development, and also trying to address the issue of training, both research and clinical training in managing the traumatic brain injuries. We also focused on developing an mHealth-based traumatic brain injury registry using open source mHealth tools, and deployed that registry on Android tablets. If we focus on this registry development and implementation alone, this is a subject of another presentation, so I'm not going to dwell on that. But in brief, I can say that this was a very customized data collection tool that we developed. We trained the hospital staff to use that tool on tablets, enter the data, send it to a secure server, and this was done by the staff within the hospital, not by extra data collectors. So we deployed the registry in the Mulago National Referral Center, referral hospital, which is the biggest tertiary care hospital in the entire country. It is the national referral center for all injuries and other diseases. This is also the only public sector hospital that provides definitive high quality care to neurosurgical patients, and traumatic brain injury is a part of their program. So now I will focus on our analysis, which actually talks about the determinants of emergency department disposition for the TBI patients in Mulago Hospital. And I chose this topic because of two reasons. One is that it highlights not only the burden that we see in the emergency department, but also it focuses on a couple of things that reflect on the quality of care that is being provided in the so-called high volume tertiary care hospitals. So the aims of the study, like I said, that we will talk about the burden, the risk factors and outcomes of TBI patients in Uganda, but also try to determine the factors that impact the emergency department disposition. So we enrolled all the patients who had suspected traumatic brain injury, either as isolated injury or as a part of multiple system involvement. And they were included whether they came directly to Mulago Hospital or were transferred or referred from other hospitals. Since this was a research project, we had to make sure that we take consent or assent or parental permission to include the patients. So this became sort of a limitation because a lot of patients who did not have next of kin at the time of arrival or who had depressed consciousness at the time of arrival were excluded from the study. So that was one of the, so the data that I'm going to present focuses on 15 months starting from May 2016 to July 2017. We obviously focused on patient-related factors, the injury circumstances, the mechanism of injury and injury severity scores. We tried to document, well, it was documented, the Glasgow Coma Scale, which was documented at the time of arrival and after initial life-saving treatment was provided, so it was recorded twice within the emergency department. And the outcome variable was collapsed into 4 categories: died, discharged home, admitted, died in the emergency department, and others. Now, it's important to understand that for this data collection, we focused on the initial 24 hours or from the time of arrival to the discharge disposition, whichever came first. So many people were actually waiting in the emergency department even after 24 hours to have a decision on their disposition. So I'm not going to go into the details of the statistical analysis at this time, but we used simple logistic, a multinomial logistic model, and which was followed by adjusted multinomial logistic model. And we selected the final model based on the ICAIK information criterion, the lowest AIC. And I will show you the results in a moment. So here are the important results. And do I have this? Okay. All right. So you can see here that the majority of the patients were obviously males, and they were of younger age group. And they were equal representation from urban and rural communities. Place of injury, the most common place of injury was streets and highways, considering that majority of the patients actually suffered from road traffic injuries. But if you look across the discharge disposition, there is not much difference between these 4 categories in terms of distribution. So the p-values are indicating that none of these differences were significant across different categories of discharge disposition. However, there are a couple of interesting findings here. So even for age group and sex distribution, there was although the males were predominant, but the age distribution across genders were comparable. 35% of patients were discharged home from the emergency department. 43% got admitted. Others category, which included referred, left against medical advice, waiting for decision, were 19%, and 3% of the total population, of the total sample died in the emergency department. This is also another interesting slide. And there are two things that you need to focus on here, that approximately less than a third of all the patients actually arrive within an hour of injury. And more than 50% of all the sample required 2 hours or more, and some actually were seen in the hospital after 24 hours from the initial injury. This is the difference between the first Glasgow Coma Scale and the second Glasgow Coma Scale, and although majority of them had a favorable GCS, which means that the GCS score, which was high, mild head injury, a third of the entire sample actually suffered from a drop in GCS during their emergency department stay. This should not have happened, but this is seen here. There are a lot of patients drop their GCS 1 point or more. And this is the impact of injury severity. You can see that there are number of serious injuries, change in GCS, Kampala trauma score, revised trauma score, all were significantly different for patients who were discharged home versus those who got admitted or were died in the emergency department. So, and this is, and this was statistically significant too. So this is our final model that we chose based on AIC, and it shows that it shows one most important predictor of emergency department disposition, and that is a drop in GCS. So if somebody has suffered a drop in GCS from the arrival to the second GCS recording, this is the most significant predictor for admission or death, and even for those who are waiting in the emergency department for decisions. So it is possible that you came here in the emergency department with mild head injuries, good shape initially. But if you drop the GCS, either you will get admitted, there is a possibility that the patient might die, a very high possibility. And the third is that initially the person who was looking good is now waiting for a decision, either a CT scan or other things. So this is one of the most important lessons that we learned, apart from a number of serious injuries, etc. So the final take-home points. We have seen a high burden of traumatic brain injuries. Over a 15 months period, we saw almost 4,000 patients in the emergency department with traumatic brain injury. And that is all, despite we excluded severe injuries from our analysis. So this is a big burden. Road traffic injuries and intentional injuries are the predominant cause of TBI for the patients seen in the Mulago Hospital. Delay in the hospital, delay in reaching the hospital was commonly observed, although it did not have a significant impact on ED disposition decision. 60% of those who died in ED had mild injury on arrival. This is mind-blowing for me, that if you had a favorable GCS on arrival, why would you die? But it's also important to know that that based on the data we have, a third of those actually had a drop in GCS, which begs the question that is there a problem in the resuscitation efforts? Is there a problem in investigations? Is there a problem in definitive decision making because of which they suffer a poor outcome? Post-resuscitation GCS is the single most important, and this is the same thing that I just said, that the conditional odds for having admission as well as death in emergency department is determined by initial GCS, a drop in GCS, number of severe injuries, not by what mechanism or what type of head injury you had, whether you were young or old, whether you came from an urban or rural environment. about 15% of patients were still waiting for final disposition, even after 24 hours of ED arrival. And this reflects the problem with patients finding it difficult to have a bed in the ICU, or delays in CT scan, delays in moving to operating room, and that is why these patients had a delay in final disposition. So this finding should lead to improved assessment and resuscitation guidelines, and targeted efforts to identify actual processes where we can put our time and effort and training to make sure that TBI patients, once they have reached the hospital, pre-hospital care we cannot at this point change. But once they have reached the hospital, the in-hospital care guidelines, processes, and outcomes should be well defined and should be followed and should be communicated to all those who are involved in the care. So thank you very much for your attention. This project was funded by an NIH grant. Dr. Hyder was the PI. We are the team, and I'll be happy to answer any questions. Thank you.
Thank you, Amber. In the interest of time, I think let's hold off questions until the discussion part at the end. But this was an important example that showed you that such data, while currently not available in many low-income countries, is really possible to collect, and it could be used to really guide planning of services and improving of services to improve outcomes. Our next speaker now is Dr. Martin Eichelberger. Dr. Eichelberger is an expert in the field of pediatric trauma care and injury control. He is a pediatric surgeon and founder of the Emergency Trauma and Burn Services at the Children's Medical Center in Washington, D.C. Also importantly, he is the founder of Safe Kids Worldwide, which, as you all know, is a large network of organizations working around the world to improve child injuries. So Dr. Eichelberger, I'll hand it over to you, and he'll talk about, he tells me Brazil, but I know he'll talk about pediatric injuries. So.
Boa tarde. Sou brasileiro. No, I'm American. I'm a naturalized citizen here in the U.S. I was born and raised in Rio de Janeiro, in Brazil. So global medicine and global health makes sense to me, and I understand the challenges. Today, what I'd like to do is to give you, can you hear me okay? Can everybody hear me? What I'd like to do is to do two things. One is to show you where we are right now in injury prevention for children in the United States. And then I want to touch on a new mechanism of injury, which probably many of you have never heard of or have experienced. What I'd like to have you remember, you can write this down, because it's the only thing that you need to really remember, is that if you're going to make progress at anything, you have to be prepared. So there are the 5 P's. Number 1 is proper preparation prevents poor performance. Write that down. Because if you want to be successful, that's what it's going to take. Because we can talk about a lot of variables, but if you're not ready and you're not patient, you'll never succeed. So today, I wanted to cover some of the things that we have done. The Children's National Medical Centers in Washington, D.C. It sees about 10,000 kids, admits 10,000 kids, and about 1,000 of those kids are injured kids. And I got interested in this because nobody cared about injured kids. Everybody thought somebody else was taking care of it. Pediatric surgeons are interested in taking care of cancer, taking care of newborns. Well, the reality of it is the leading cause of death to kids are injuries that, and 90% of the time, are preventable. So today, you're sitting here, and this is what we're going to talk about, which is injury control. There are 3 major components to it. Most of you at this institution understand that. When I started, I understood this, but I didn't understand prevention. I had no idea. And the terminology between these two are totally different. They're not the same. So as soon as you start talking about injuries to kids, People's minds start to glaze over. And rehabilitation is probably the most difficult for me of all of this because it has to do with long-term sustainability. Okay, here's another thing you ought to write down. This is a solution to the problem. You asked a question about whether information is important to solving the problem. Yes, it is. It's very important because you and I are going to talk to each other. That's information exchange. And we're going to say to ourselves, well, how do we do this? That's creating a coalition. The two of us, you have to find a partner. You have to find a teammate. You can't do this by yourself. And if you do, you're going to waste a lot of your time. So you need people and an environment where you can actually put all of these things together. Getting good data, we just saw that in the last two presentations. But the question is, what do you do with it? I'm a surgeon. I want to do something. I don't want to think about it too much. And that created a problem when I got involved in injury prevention. You had to do more thinking, analyzing, before you could get to the solution. So this is sort of a bridge between the two. Education is really important, but education who? Who are we going to educate? Everybody. The entire system, the continuum of care has to do with from the time the patient is in a community to the time they die in that community. And I look at injury control, I look at really trauma care as when injury prevention fails. When the community fails the patient or the individual or the people that live in the community, then you have a patient. You have Karachi got 21 million people. I thought Rio was big with about 12 million. I mean, it's like it's a little city, a little community compared to Karachi. Well, that's a big, major problem. And so you can only solve the problems that you can control. So you have to take a long-term view of how you're going to solve this problem. So data, coalition, education, the media, very important. Legislation is also important because you have a great group of people, but if you can't communicate your problem and keep it very simple, guess what? Nobody's going to believe you. If you don't have economic data, nobody cares. They don't care how many people die. They just want to know what the economic impact is. So you've got to figure out when a kid gets hit or a patient dies, what's that cost to society? You have to go from this very simple to a much more global view. And you have to be able to work both ways. If you don't, then you lose. This child was a child who was in our intensive care unit for 6 weeks with a burn. It cost $1 million to take care of that child for that period of time. Well, guess what? If you put a child in a booster seat, you're going to save society $71 for every dollar you spend. Look at bike helmets. It's a simple thing. A bike helmet costs what? $30, $40? Unfortunately, don't have bike helmets in many of the countries I went to. They didn't even know how many kids were getting hurt. They didn't even know how many kids actually had used a booster seat. So what did we do? We went out into some big mall, started counting heads as the cars went by. Is that good enough? Yeah, it's good enough. You got to start with something. You got to start with some hope. You got to have a database where you can prove to people that you can make a difference. So these are the mechanisms of injuries for kids now in this day and age. So you can see just fires and burns, there's an 83% decrease in the United States in the injury death rate to burns. It doesn't happen anymore. Well, guess what? That's a huge savings to society. If you add up what that child was worth over a period of his entire career, you're going to find that there's a significant savings. Motor vehicle and drowning. This is over a 30-year period from the time we started. This is when I got interested. We started in I don't remember what the date was, 30 years ago. And 30 years ago, I knew nothing about injury prevention, zero. I just knew the kids were dying. And we had the best trauma system in the world. There was nobody doing it better than we were. And guess what? They were still dying. So the real issue was we were working in the wrong space. Being inside a hospital wasn't where the solution was. The solution was out in the community. Nurses didn't want to put their kids in car seats because they were having injuries to their spinal cord. And they couldn't walk and the kids weren't normal anymore. And the nurses said, I'm not going to put my kid in the car seat. Dr. Eichelberger, you smart aleck. I said, well, why are you doing that? So all of a sudden now, there are all these problems starting to face us, and we're saying, well, how do we solve this problem? Where we have problems today is in suffocation, but these are kids less than 1 year of age. And that's almost an administrative change, because all of a sudden it starts getting counted because the kids were suffocating. And so if you're counting data from 1 to 14, it's the leading cause of death of kids worldwide. Outside the United States, drowning is much more important a factor than it is the motor vehicle when you start looking at data. And every country is about 30%, 40% are kids less than 14 years of age. It's a huge population. That's the future of your countries. So has it been successful? Safe Kids and our collaboration with the Johns Hopkins Public Health Department, all these different coalitions that were formed. Coalitions were made up of groups of people who want to do something well in their community. And you can see that there's been almost a 61% decrease in the injury death rate in the United States today. That's outstanding. Guess what? Nobody does that by themselves. So how's it done? You start building coalitions. As you can see in this line, as you increase the number of coalitions, you have a decrease in the number of deaths. That's pretty cool, isn't it? Come on, smile, man. You guys got to get with it. I mean, surgeons would be jumping up and down and sleeping in their seats, you know? Come on now. So today I want to talk a little bit about injury prevention from the tertiary level. Did you even know that existed? Primary, secondary, tertiary prevention. Did you know that? You knew that? You better. Here's your professor sitting right over here. He's going to get after you if you don't know that. So the reality here is that once the community fails, you have a patient, and now we're trying not to reduce the injury death rate, but the preventable injury rate. So now we're trying to keep people from dying. That's a lousy job. That's not where we should be focusing. And as a surgeon, it's hard for me to convince some of my surgical colleagues that they ought to spend more time doing this. So these children have a big head compared to the rest of their body. This kid's checking his stream here. He happens to be my son, by the way. He's 43 years old and doesn't know I use this slide. You know, I was gonna show it off at his wedding, but I figured his wife wouldn't appreciate that very much, or he wouldn't appreciate it. I don't know. But the point is that the head is a significant area of problems. You have a very large surface area to their body mass ratio, and they have a foreshortened extremities. So now, if this child is placed in an environment where he steps on a landmine, can you turn that light out? Or I guess these lights have to stay on there. This is a 2-year-old who stepped on a landmine in Afghanistan. And I got a call the next day from the surgeon who ran the combat unit in Kandahar. Said, Dr. Ike, I stopped the bleeding, but I don't know how to take care of the child. So all of a sudden now, you have an anatomic problem that nobody can take. They can take care of the simple stuff, but the reality of it is, who's going to take care of this kid? So that started me thinking about blast injuries, because in about 10 years ago, during the Afghan and Iraq war, nobody had really run into this problem, except in the US, where we had a couple of explosions where kids and people were dead, and nobody really thought too much about blast injuries. How many of you in this room have ever seen a blast injury? Okay, that's pretty good if you've seen a blast injury. Here in the US, it's usually an explosion. Just happened in Boston with the explosion that they had in Boston. And this is something that nobody thinks about that's really important. So if you want something new to work on, this is it. Any place that there have been any kind of war activities, terrorism, and you can see it's pretty significant worldwide. A lot of Africa, you can see that China is, for whatever reason, very protected from this particular injury. I'm just going to look at just landmines. You can see 30% of kids end up with a disability. In most countries, if you're disabled, you're going to die. You're going to be put outside from the family. The family is not going to want to take care of you. We found that in Afghanistan and Iraq, because if you took a kid and resuscitated the child and put him back in a hospital in Kandahar, that kid was going to die. So now you have a child that's got a bad injury, and what do you do with them? Well, what I'd like to show you here is the Not moving? Okay. There's a group of people right here. You can see the amount of dust. It's a very arid, dry place. The terrorists actually took pictures like this of these activities occurring. Whenever they put an IED in, they took pictures of it to make sure that they could get on the internet and demonstrate what a great thing that they had done. So when you look at this, just look and remember in your minds now all of this debris, the amount of force, which is called barotrauma. Barotrauma is when the bomb goes off, you could be standing across the room and get hurt real bad. And the reason for that is that anything that has air in your body expands and then it contracts. So you have this massive expansion and then it contracts. And that wave just itself, without any of these other factors that you saw here, can make a significant difference. So here's the wave. This is the physics. It's all physics. You have this huge increase in the pressure. It comes back down, and then it goes negative. So what in your body is made of air? Give me one thing. Your lungs? You don't have any idea? Your nose? What else? Your intestines, okay? What about your brain? Just think, in your mind's eye now, anything that, this is a multifaceted anatomic and physiologic stress that you're going to see on this patient. There are a lot of things going on. So when they come through the door, you've got to be thinking multi-system. Keep me on time there, Dr. Hyder. I start having fun and it gets to be a problem. So this is what you see. You see with barotrauma, the tympanic membranes are very common to perforate these. You can't hear after you have that. And then you can see from penetrating and blunt and burn inhalation that there are many things happening at the same time. So when kids are out playing, and you have a 3 or 4 year old standing right here, all of a sudden an explosion goes off and they have a burn, they have an amputation, and you're saying to yourself, how do I treat this kid? Well, there are 2 steps. This is the way you think about it. One's physiologic, one's anatomic. You can't let the anatomy deflect you from the anatomy, or from the physiology. So when you have hemorrhage, all of a sudden now you have a variety of things happening. You have acidosis, hypothermia, and hypocoagulation. The most important thing you can do is stop the bleeding. So the physiology is called damage control resuscitation. The anatomy is called damage control. Okay, there are 2 different steps in this process. And whenever you start giving people a lot of blood, they have a lot of things happen to their system. And so one of the things that we found was that the more blood you give patients, the less well they do. Here's a child that's got a head injury, he's got an amputation of his arm, he's got an amputation of his leg, and he's got a vascular injury here, plus, if you can't see real close, but there are little pock marks all over. He's had penetration, he's been thrown, as well as being penetrated. So this is the most important thing, I guess, in the resuscitation of the child. It's not ABC, it's C, ABC. So circulation is first, which is to stop the bleeding. So you can teach somebody in the field to stop the bleeding. And the ratio of the blood is 1 to 1 to 1, and in kids you can see that that ratio also carries, so that you can almost reproduce whole blood with packed red blood cells, fresh frozen plasma, and platelets. It used to be that everybody would say, do never ever put on a tourniquet. That's been demonstrated to be totally wrong. Your survival rate goes up if you can stop the amount of bleeding. Are you a surgeon? Anesthesia. See, well, he gives a lot of blood. He's saying, guys, don't do this. Put the tourniquet on. In the airway, the thing that's interesting about this is that the airway has a lot of missed injuries because it looks like it's okay at the beginning. You get a lot of hemorrhage. You got a lot of issues that you need to be thinking, we've got a problem. Number two, if you have breath sounds and a decreased blood pressure, you don't need an x-ray. You just put 2 chest tubes in. The head itself, I think probably the most important thing about the head is the barotrauma, where you have the opportunity, if you do the right things to these patients, to provide at least, the pitfall being that the patient doesn't look too bad, just like you said with your presentation. The patient came in, 60% of the patients look fine, and then they die. Well, that's common. In my experience, you got to be real careful with this. So this type of a child now, what we try to do is not to give them very much volume by using hypertonic saline. And then the other technique that's new is craniectomy. So what you end up seeing with a bullet wound to the head of a child, you can see here's the normal, and then you can see the bone has been taken off of this right here so that it allows the brain to expand. There's controversy as to whether or not that's a reasonable thing to do in kids. But sometimes the pressure's so high there's no other option. And what you end up doing is taking the bone out, open the door up so that you can at least expand the brain and get rid of the blood in there to reduce the pressure. The pulmonary is another area that's really critical. This child looks like the child's insufflated, but you've got now a child that's got a decrease in a collapse of his lung. He's got a pneumothorax, you can see here, with the heart and the lungs, everything shifted that way. And when you put a chest tube in, you've got this lung that's all contused. The problem with this is that the smoke that you saw and all those noxious chemicals are now inside their lung. And one of the things that you're doing in your emergency room is giving the patient too much volume. So the lungs are taking a big hit, and it's like a sump. It takes all the fluid you're giving the patient into the lungs. So that means over a 24-hour period, those lungs get worse. You can't oxygenate the patient. In the abdomen, the other thing that's really important is that we're not closing the abdomen anymore. We're leaving it open because the edema is circulating now throughout the entire system. Edema of the head, edema of the lung, edema of the abdomen, edema of the extremities. So we close this in a very delicate manner so that we can get to what I think one of the most challenging problems is the extremity, because that's where a lot of these patients have a lot of bleeding. So you have to stop that. You stop the bleeding that they have in a big injury like this. And then you can see here, here's a vascular injury that this youngster's sustained. He's bleeding from the artery and the vein, so the tourniquet was put on above and below, and it stopped the bleeding. Everybody used to say, don't do that. Do it. It's the one way you're going to help the physiology of the patient is by reducing the amount of fluid. And then external fixation. So one of the problems you always have in the operating room is that orthopedic surgeons want to go first. Oh, let me fix that bone for you. Answer is no. What you do is you put a shunt in the vessel, you do a fasciotomy, and then you let them come on board. So that this shunt is a plastic. You can use a variety of things I won't go into. But at the same time, once you fix that, and it takes you about 5 to 10 minutes to do this, then you go down here and do a 4-compartment fasciotomy. Because if you don't, they're going to lose that extremity. Don't even ask questions. You just go do it. On both sides. You're seeing one side. You have to do it on the other side, too. How many surgeons have in a room here? How many surgeons? Okay, when was the last time you did a fasciotomy? About 10 years ago. Have you ever done a fasciotomy? Okay, I could teach you to do that in about 5 minutes. But the reality of it is, very few surgeons know how to do that. They found that out in Iraq and Afghanistan. All these guys were losing their legs because they weren't doing the fasciotomy correctly. They had an incision, but they didn't do the anatomy. So in pediatrics, less is more. If you fix this bone, these kids can get up and walk around without too much trouble at all. So in summary, the things I want to leave with you is that you got to avoid the lethal triad. You've got to reduce the amount of volume and blood that you're giving these kids. You accept a low MAP, mean arterial pressure. Don't have to be normal. Keep it low, just so you have enough urine perfusion that you can make it. And then the transfusion rate. Don't give them blood if they don't need it. And everybody wants to give more and more volume. Do not give them Ringer's lactate, please. It blows everything up. And then finally, you've got to be thinking about the anatomy, which is all these compartments that blow up. The head, the abdomen, the extremities, so that you have to open those spaces up. That's basically as simple as I can put it. So therefore, what I've tried to get across to you today is, number one, you have to be prepared for this. Number two, there is a vaccine that you can use. The model for prevention can be used for treatment. The whole issue of having data, education, creating coalitions. What's a coalition in the operating room? It's a team of people talking to each other. They come from different places. And then finally, the most important thing is to realize that you can only do so much if you're prepared. Go find a buddy, a teammate, talk to each other, come up with a solution. Thank you very much.
Thank you, Dr. Eichelberger, for that. I'll now invite all our speakers up here, and we'll have a discussion. Pardon? 2 minutes. So we'll, you can sit there. What we'll do is we'll have a couple of questions and then ask our panelists to respond. So anyone with any questions about anything they've covered, or even things they haven't covered, maybe? Isaac?
Thanks for the great presentations. Dr. Junaid, this is my question to you. You talked about emergency medical care, talking about a bystander, the transport, and the clinical care. And you also talked about sustainability. So when you are doing programs or planning programs, should you consider, if something cannot be sustainable, should you still go ahead to do it, or you should focus on things that can be sustainable and then have long-term impacts? Thank you.
We'll try to take a couple more if there are any, and then proceed on. Nino and then Eric.
Hi everyone, thank you, great presentations. I have a quick question to Amber. Amazing results, very interesting, and I wonder whether you were able to share with the either hospital people or the government or like Ministry of Health, and what is their feedback and how they're just going to improve the situation, because it's very interesting to know. Thank you.
Eric, there's one here too.
So my question is to Junaid and Amber. I think in your presentation, Junaid, you mentioned that human resource is the biggest constraint. So what aspects of human resource are we short on? Is it absolute numbers? Is it skills? And then there are also arguments around human resource in low and middle income countries about effective use of the human resource that we already have. What are your comments about this?
And one right here.
I just have a couple of questions. From the last speaker, actually, I thought your presentation was excellent. I thought your presentation was excellent. One of the interesting things you touched upon was the importance of hypertonic saline, for example. And I thought it's interesting when we're talking about this in global health. It is not that expensive, it's not that difficult to make, but a couple aspects is that the hypertonic saline that's normally available in a hospital is not the kind we use in the operating room, because that type is actually toxic. It has to be a buffered one that's buffered with acetate so that they don't get a high chloride load. And you find that most hospitals in the United States actually do not, that's not something that is available or known widely within the United States. So when you get to other countries, usually when I am doing a project there, I actually bring the components of it, the sodium acetate and 24% sodium chloride with me, which I get for very inexpensive, and I can just make it myself. But it's just it's an example of something where the knowledge base of that is not widely known internationally in low middle income countries, and it's related to the lack of knowledge of it here. In regard to the second speaker, I had a couple questions for the percent. I was curious as to if you had any information regarding, and you probably do, a comparison as to what percentage of head injuries have a deterioration of Glasgow Coma scales between the first and second measurement in the United States. Because as you know, there are many different types of injuries, like epidural hematomas, where it is classic that the person comes in at one level and then they deteriorate. And when you're in a situation where you have limited access to CT scans, you may have, hopefully you have one. If you do, it may be, you're getting access to it, especially in a large center, may be challenging. And then there may also be a possibility, well, in much of sub-Saharan Africa, I'm not sure about Uganda, but the other countries I've been into, you may have a CT scan available, but if they assess that the patient can't pay for the CT scan, it will not be practically available to that particular patient. So, so I think these relate to the other question as to, trying to figure out some of the things to make these solutions sustainable. They become complicated in the economic system that the country has, in comparisons of knowledge base between what is the best thing practice to do and then what is actually available there.
Okay, thank you for those questions. We can go from Junaid to Dr. Eichelberger and respond to those.
Thank you. The first question about sustainability is a tough one, right? The way I look at it is that eventually emergency care has to be funded in many of these countries by the governments. I've worked in private sector all of my life. The amount of resources required, and because you don't have for-profit model that applies across, you'll always have problems with private funding in emergency care. However, what private funding does do is that if it's smartly used, and when I say smartly used, you have to engage the government early, even if you're putting the private money in. You have to market it very, very highly to the general public, so there is a demand creation. And thirdly, you show evidence that it works. So once you create a model in the private sector with some sustainability, which is not long-term, but if you have all of these three elements, public sector will have to get involved. If not today, then tomorrow. So I think I will not stop doing the right thing, but I will keep my eye on the price and say, well, this is where I want to go, and I need to engage the public sector and the governments into this. So I don't know if I answered your question. The second question was about human resources. So there are two types of human resources. Like there's skill level human resources. So people who can intubate, put chest tubes in, give IV fluids, put an IV line, could do IOs. Those skills are relatively easy to teach, and we have problems there, but not that big of an issue. I think a lot of people go in and do these short courses and try and solve that problem. The bigger issue is thinking piece. The more complex thinking is where the issue is. Having worked there every day, you get into trouble. There are people who are much better in operation because they do this so much more often, skill-wise. But the decision making is where I think we need to actually focus on for the long-term improvement. And this is when I talk about leadership, when I talk about longer-term training, mentorship, and some sort of structured training. I think that's where the big gap is, and I would like to focus on that.
Thank you for the questions. First, Nino's question. This is very close to our heart, and we have already communicated the initial results to the local team. The results are actually being used to create a customized TBI management guidelines. And the reason that I'm saying customized is that there are a lot of TBI management guidelines available, right? But when you work in a very resource limited setting, those timelines, those protocols usually don't work. So you have, if somebody has a low GCS, they have to get a CT scan within a limited time period. But if CT is not available, what to do? So we are in the process of not only involving Ugandan surgeons, but surgeons from the region to think about how can we create some guidelines which are applicable to a resource-limited setting, and to at least focus on those patients who have the probability of a good outcome and suffer because of delayed decision-making or logistical issues. So that is one of the priorities. Sir, your question is very important. And this is an easy one to answer because we have that data. We did not put the diagnosis into our model because that was something that we could have done. But this is an easy one. The thing that a lot of patients actually were referred from other facilities because this is the only public sector neurosurgical teaching hospital was the fact that the initial diagnosis was made, but either they were referred for an advanced treatment or further investigations because in those hospitals the CT scanner was not available or not working. And even those, almost 45% people who were referred from other places, they had a favorable GCS on arrival. So, so we can dig deeper into the factors, and we should and we want to, of what happens within the emergency department and many people actually have a lower, multiple injuries. So GCS is not just because of head injury, it's because of poor resuscitation of a hemorrhagic shock that you can go into a depressed level of consciousness. So these are the things that we are looking into, and we are working with our local partners to answer some of these questions.
Thank you. A couple of, I think your point about the hypertonic saline, the way I look at that is that that's an issue that you can't solve in every country, and that you can't be perfect. So that you could actually resuscitate a patient with normal saline. The problem with that is it creates more volume. You get more edema. The issue of trying to communicate this to the right people. I mean, I look at trauma as a political disease. Because as soon as you get into the community, it's politics. Building a coalition is political. Getting education. So the thing that strikes me is that when I first started this, and we were trying to figure out how we could change America, how are we going to change? Because at the time that we started doing Safe Kids, our intensive care unit had more kids with head injuries than you could count. Today, you can't find one. It's very rare to have a child with a head injury admitted to Children's National Medical Center. Because of the fact that they're wearing helmets, they're restrained in the vehicles, all of those things that happen in the community are now happening. So going to your question back there, is that you got to be satisfied with good. It's never going to be perfect. You got to make that first step, and then you got to find a teammate. Personally, you got to find a teammate who's outside your specialty. Somebody that has like-mindedness, and they come in a lot of different backgrounds. The intellectual part of it is not a medical issue. This is how do you get people to change their behavior. That's what we're doing. That's what you guys are trying to learn how to do, change people's behavior. Well, you cannot do that if you worry about every time you can't get it done. You've got to make sure that you're controlling those things that you can control so that it's political. One of the things you have a problem with excellence is that good is enough. Because the next time, the next year, this longevity, sustainability issue, you really don't know what that is until you field test that a little bit. You got to go try it out a little. And the reality of this is that if you're idealistic, you're going to have a rude awakening when you get out into the community and try to change some of these things. But you got to have hope. You're the communicator. You're the one that has the knowledge, the interest. But I can tell you, our coalitions throughout the U.S., we have 400 coalitions. We're in 31 countries. There are no doctors running those coalitions. There's not one coalition that's run by a doctor. And a lot of them don't even have an MPH. They have no idea what public health is. But they're mobilized because they know their kids are getting hurt and that they want to do something about it. And this is an ethical good that you can sell to the community. And you've got to do that patient by patient, individual by individual. Think about saving one kid's life, and then all of a sudden, if you get the systems put into place, which may take 10 years of putting a system into place, you can't. The problem is you can't put yourself in a position where you get distracted by putting everything into place. Take one step. That one step will lead you to the solution that you're looking for.
Okay, thank you. Thank you for those. We'll take maybe a couple more questions. I know we're running a little over time. If there's any burning questions. If not, I'd like to ask you all to join me in thanking our speakers today for the wonderful session we've had. And thank you all for coming either in person or participating online. Be on the lookout for our next event, which will be announced soon. So follow us on Twitter, Facebook, etc., and you'll hear about it. Thank you again.